and that takes us on to our next talk, which is to be presented by Jennifer Misak. And this is really exciting work. The report is really impactful. And again, I'm hoping the magic of... Here she is, Jennifer Misak. Welcome her onto the stage. And she's going to perform on the Lowry stage for us now.
Thank you. Can I give you that one?
Please do.
Thank you so much. And can I take
That's your buttons.
Great. Thank you. Right. Thank you ever so much for the intro. Just to say, having heard this morning from those fabulous people with lived experience, that this can seem quite jarring. So I'm going to be talking about costs. It can feel quite cold, actually, when we're talking about putting monetary values to what is essentially people's lives and people's rehabilitation. But it's really important, as it's the language that government policymakers in particular are dealing with every day. We've got the budget coming up in a few weeks' time, and it's these kind of big figures that really make a difference in terms of the impact and explaining the costs of things like acquired brain injury to the UK can have. So just to make that point, because obviously I'm about to aggregate up people's experiences and put monetary figures on them, so it always feels a little bit strange. But I was a senior civil servant in both the UK and Scottish governments, so I've got quite a lot of experience of being campaigned to on the other side, so being lobbied and providing advice to ministers, which is all about, you know, the kind of hard metrics and the hard figures. So how did this come about? So obviously, as was just discussed, UKBIF published the Time for Change report in 2018, and they were looking for an update, and especially an update to this figure which had been going around, I think, for some years previous as well, from 2016, which was that TBI, so traumatic brain injury, cost around about £15 billion per year to the UK economy. Now, this was obviously slightly out of date by the time we're looking at it in 2025, but also there's been quite a lot of evidence, really, and important data gathered since then, which we can use to really update this costing. So a large part of my work as a health economist is doing something called cost of incidence modelling. So this is taking diseases and conditions, taking the incidence and the caseloads of those, and working out the costs of various different elements within that. So we also look, if we're obviously trying to cost a disease or condition, at the counterfactual. So in all of the numbers I'll be talking about today, our counterfactual here is as if there was no acquired brain injury at all, as if every person who has an acquired brain injury, be that a stroke or a traumatic brain injury, that they are actually living and have the kind of health conditions of an average person. Now, you'll have to bear with me on that. The average person obviously doesn't truly exist, but in the data it does. So that's what we're looking at as the counterfactual here. And so we're saying these are the costs over and above what would happen in the general population with average health otherwise, taking out the acquired brain injury. One of the things that's obviously been really key, and especially in terms of influencing policy change, and one of the aims of this piece of work really for UKBIF, was to get that impact and to really say, okay, how much is this costing not just the NHS, but in other ways? So the kind of hidden costs in terms of productivity loss, so people not returning to work as quickly as they may do otherwise because of delays in rehab, or not getting the care they need to be able to play an active part in society in some way. And the evidence, as I said, is ever evolving. The research out there is ever evolving as well. And we've now got quite a few decent surveys set up, for example, looking at people returning to work after conditions, but they don't always disaggregate for the conditions. So it's an ever-improving evidence base, really. And why is this important? So good quality data in particular, and I'll talk about some of the gaps in this area a little later, is really essential for the robustness and the accuracy which we need. So as a health economist, I could pick a number out of the air, really, but it won't mean anything to use that number if we're going to policymakers and trying to make a case for more spend in different areas, which could lead to cost savings in other areas as well. And obviously, with any modelling, any economic modelling, the outputs are only as good as the inputs. So, the more the data improves in this area in particular, the better we'll be able to be more specific, we'll be able to disaggregate among different areas of ABI, and we'll be able to put a better case really together as well. So one of the things we always need to consider when we're looking at doing any piece of economics work and using data in this way is who we're influencing. So, your kind of standard for evidence and robustness might be different depending on the audience. If we're looking at media and campaigns, big shiny number, fabulous. If we're looking at ministers, government departments, Department for Health and Social Care, etc., we really want to be able to tease out the different elements to the costing and to the kind of policy interventions that we can make as well. So I follow, having been a previous employee at Her Majesty's Treasury, I follow the kind of Green Book analysis, as it's called. So this is the standard, rather chunky book of methodology, and kind of a really gold standard for costings in this area. It's also obviously similar to the OBR in terms of the Office for Budget Responsibility and their approach to things like dealing with ranges and averages and things like that. So what was our big number? The cost of acquired brain injury in the UK economy, we estimated to be £43 billion a year, and that's based on data from the last available set of data, basically, so 24-25. For the first time ever, I actually calculated wellbeing costs in this area as well. So while the 43 billion was an update on the 15 billion, and I'll go in to explain why those two figures are so wildly different, the wellbeing costs, this was the first time we'd actually put a monetary value to the wellbeing loss from ABI, and that was 91.5 billion. So a massive, looking at the scale of those two figures, massive amounts of money attributed to the care, the treatment, and the ongoing societal impact as well. So whilst doing this piece of work, I also looked at all the research in this area, and we were very fortunate actually to have some of the data from the ROC, so from the Rehab Outcomes Collaborative and Professor Lynn Turner-Stokes, and some of that research alongside the National Centre for Rehabilitation's economic business case, which is really a really useful piece of work in this area as well. We can actually come up with a kind of benefit cost ratio of about 16 to 1. So for every for every £1 that we put into long-term rehabilitation, we're looking at a cost saving of around £16 to the UK economy, which are not many programmes and not many kind of government services which provide that kind of ratio, really, that higher ratio. So I said the economic cost of ABI was £43 billion, and this splits out into around about 20 billion for the NHS and local authorities. So that's acute care, of course. Rehabilitation and long-term care is there as well. That's about double the acute cost. And then social care, which is through the local authorities usually, is also added in there. We also have the lost productivity costs. So this comes from people of working age not being able to work as they would otherwise without ABI. From patients, that's around about £16.6 billion. And from their carers as well. So this is informal carers who would otherwise be in paid employment but are providing care for ABI patients. I also was able to disaggregate and pull out, using some of the education and criminal justice data. The cost on special educational needs, which is around just under £1 billion, and the costs in the criminal justice system of TBI alone. So that's only really looking at those people in the system who are diagnosed with a TBI, of around £600 million a year. So obviously some really big figures there. As we might hear from later, the special educational SEND cost could be a lot higher, to be honest, and probably should be, because we would like everyone, every pupil to be receiving the special educational need and support that they need. But yeah, that's it broken out there. The one thing I should say as well is I'm talking here about the cost of ABI. Because of the data, and I'll go on to explain the data issues, because of the data issues, we actually broke ABI down into traumatic brain injury, brain tumour and stroke, and it was only those three fairly substantial groups that we were actually looking at. Other smaller groups which may have significant, or do have significant costs, there wasn't the data there in terms of the cost to be robust enough really to report on that. So what does this kind of big figures compare to? Well, we know the annual NHS budget is around about £180 billion a year. So we know that ABI is comparable to about a quarter of that if we're looking at a scale. We know it's around about double the size of the adult social care budget in England. It equates to about £800 million a week, which is a pretty staggering figure as well. And yeah, as I said, we've got the budget coming up in a few weeks' time. When you work out how much 1 pence is on the basic rate of tax, then this kind of £43 billion is around about 6 pence on the basic rate of tax. And that puts it in some context, I think, there as well. So pretty staggering. Then we looked at the wellbeing costs. So this isn't actually this isn't spent in the economy, but it's estimated monetised impact of the loss of wellbeing. So what we do is we look at something called quality adjusted life years. So this is the amount of life years which are lost through, obviously, mortality, early mortality losses, but also from morbidity. So from people who have a lower quality of life because of their impairments and because of their ABI. We looked at patients, obviously, in particular. So around 43 billion of that 91 billion comes from patients alone. But actually, partners and widows need to be included as well, because there's a massive impact on not just the patient, but their families as well. And actually, partners and widows is a slightly higher amount in terms of the wellbeing impact there. And this is all coming from various surveys, mainly European but also global, looking at the impact that disability and different conditions has on a person's self-reported well-being. We also looked at children, the impact on children, where patients have children, and also carers as well, which is the slightly smaller amounts, but that's partly because the data is very insignificant there, really. It's very small. So yes, so a total of the equivalent of £91.5 billion of wellbeing cost. One of the things I should say, so the report is published. It's published on the UKBIF website. And this is one of the tables at the back. You won't be able to see the figures very well, but just to point out really that we have the 4 nations covered, so England, Scotland, Wales and Northern Ireland are separated out in those tables, so we can see the different costs for them. We have head injury, stroke and brain tumour separated out as well into different types of ABI that were covered. We also have the various different costs, as we saw in that graphic before, so whether or not it's acute care, rehab, and the productivity losses, etc. And then the UK totals at the bottom. So hopefully this will be of use to those people working in the regions and different nations of the UK as well, to be able to pull out the different elements to the cost. Now, it was interesting hearing from Dr. Manley earlier comparing to cancer, actually, because I've also reflected quite a bit on the comparison with cancer. That's one of the other conditions that I've done cost of incidence work on, really, and costings on. And the data in that area is significantly more robust, it's more advanced, it's more specific. It's in lots of ways, as a health economist, it's much easier to work with. And coming to this area of ABI, it was really obvious from the start that there are loads of gaps to be filled in terms of the data and the research, which would have helped this study and would hopefully help in the future in terms of being able to be more specific, more disaggregated in particular. So, for example, life expectancy and survival rates, I've had to use the US data for that. It's not UK specific. It's slightly better for stroke and brain tumour, but the TBI data in particular, traumatic brain injury in particular, was US data only available. There were areas which I would have liked to include but were unable to because of the data issues. So we know there must be an impact and a cost of ABI in the area of homelessness. There must be, but it's a very under-researched area, and obviously for lots of reasons the data is particularly poor. We have lots of data these days on carers and their hours of caring and duration, but until we get to a stage where the surveys are actually apportioning that to a condition that the patient has, it's very hard to separate out, really. So that's another area. Mental health and psychiatric spend. It was very difficult to tell whether or not that was included within the NHS costs or separated out, and where that lies within rehab care as well. So some of those areas for which there is decent data, it's actually not broken down well enough either. As we know, there are researchers in the room, I know, who are looking at the number of children affected by ABI, and that's an area which it would be great to get much more information on. And then return to work rates, a large proportion of the cost, obviously in terms of the lost productivity, the economic cost, comes from assumptions really around people's return to work and whether or not they're able to return to work, and what the difference is if, with a long-term ABI in particular, and post-recovery as well. So just a bit of a plea there for me. It would be great if, the data that's available is quite often elements of it are missing. And I know a clinician in particular, their point of time with a patient, the last thing they're thinking of doing is filling out all the data forms correctly. But it does come down when we're looking at costs and being able to advocate and being able to put these things before ministers. It's really important to have that data available. I think that's me going to questions. It is.
Jenny, thank you so much. I realised I left my iPad here, but I actually got Slido on my phone as well.
Good,
so
okay.
Thank you so much. The work you've done in that document is so helpful for so many of us, and is going to be really helpful. So just to clarify, Jenny's asked, are the costs of here for just adult ABI, or can we estimate, would there be any estimates that can be drawn on for costs of childhood ABI?
So that's one of the other areas where data wasn't delineated enough, really. So this is based on hospital episode statistics. So that includes children presenting at hospitals. And then obviously there's a big calculation to get it to the number of people, the number of different people in different age groups. So it does include children. I would have really liked to have been able, obviously working age is separate, but I would have liked to have been able to separate it out and wasn't able to because of the data limitations. It was quite surprising how many people in the NHS records don't seem to always have a date of birth as well, but we'll leave that to one side.
That's so interesting.
That one's baffling.
and Erin, who we heard from earlier, asked, is the TBI data covering the entire spectrum? So this mild, moderate?
Yes. So going back to to Dr. Manley earlier, actually. If we can get, the data delineated by those kind of other classifications, that would be great. It is based on mild, moderate, severe TBI, just because the costs of the different levels of acute and rehab care tend to be as well. We can only do what the data is there.
Okay, and somebody's asked here, are non-hospital admissions not included, so this makes it an underestimate?
It's definitely an underestimate for various reasons, and that's definitely one of them as well. Yeah, I've done some calculations to incorporate some of that, but there's not enough evidence there to include everyone who would be a non-hospital admission as well. Yeah.
Are there similar studies completed in other health conditions that could be utilised to show the size of the issue? You kind of touched on that.
There are. I always feel a little bit nervous comparing different conditions, to be honest. There are costs of cancer, for example, is a big study I've worked on with Cancer Research UK. There's also Breast Cancer Now have a breast cancer cost of cancer as well. So they're all fairly comparable. I would say ABI, because of the volume and the numbers of cases, it tends to be a bit higher than some of those individual cancers, but may not be as high as the total cancer in the UK kind of costing.
Terrific. There's a mention on the Slido for a wonderful podcast that you and Chloe and James Piercy have recorded for more detail. I thoroughly recommend it. It lasts exactly the right amount of time to do your dog round the block. If for those of you who are dog walkers, I made my dog walk go really quickly. I found that really interesting.
Excellent.
So look, we've had the word road mapping mentioned already once in an earlier talk. Tomorrow we have a little subgroup of us getting together to your plea for further research. I think the NIHR particularly has funds to help us do research. I think building econometric, if that's the right word, research in, you've given us a manifesto, if you like, for further research. And so I'm really grateful for you for that contribution there. And we're going to be pushing this whole story forward to try and answer some of those very helpful questions. So, ladies and gentlemen, please give Jennifer Misak a very warm round of applause. Thank you very much.